This is Unit 4, Part 3. One quite severe type of disorder is called disseminated intravascular coagulation, or DIC. This is a situation in which you get a sudden, widespread clotting in completely intact blood vessels all over the vasculature. The problem with this is that there are tiny blood clots throughout the blood. They're very, very small, and it leads to the rest of the blood not being able to clot. Well, the blood that's in the vasculature not being able to clot at all. So it's not a question of blockage, but a question of essentially depletion of clotting factor proteins, so that the balance of the blood there cannot clot. You do get some blockage, but mostly it's because of the loss of clotting factors. It occurs not commonly, but when it does occur, most commonly it is because of a complication of pregnancy. At the time of delivery, what can happen is that some of the amniotic fluid can get into the mother's vasculature and trigger this kind of widespread minute clots, which then deplete the clotting factors. And because this is a woman who's just delivered a baby, the place where the placenta was attached to the wall of the uterus starts to bleed, and you can get actually very rapid exsanguination in those cases. It's a very serious thing, does not happen often, but can be extremely serious. It can also occur as a result of septicemia, which is when you have bacteria growing in the bloodstream, or it could happen occasionally with incompatible blood transfusions. Another type of bleeding disorder is thrombocytopenia, in which case the number of circulating platelets is insufficient. People who develop, for a variety of reasons, thrombocytopenia will show small purple blotches on their skin. These are small bleedings under the skin, and they're called petechiae. They're just small, tiny purple blotches all over the skin. It's because, as I said, you often bleed. Bleeding occurs all the time and is quickly stopped by vascular spasm and platelet plug formation. But someone who does not have enough adequate numbers of platelets can get this kind of bleeding, and evidence of that is the petechiae. It can be caused by suppression of bone marrow or destruction due to treatments such as radiation or chemotherapy for neoplastic disease, in other words, anti-tumor treatment. Tumors of the bone marrow can result in inadequate production of thrombocytes or platelets. If the platelet count drops below 50,000 per cubic millimeter, that's diagnostic for thrombocytopenia. Another hemostatic disorder of coagulation is a deficit in the synthesis of the procoagulants. Procoagulants are the clotting proteins, the clotting factors. They're produced in the liver, and individuals who have a number of different things going on this can lead to insufficient synthesis of the clotting factor proteins in the liver, and that leads to severe bleeding disorders. A very common one is caused by cirrhosis of the liver. Cirrhosis of the liver is widespread scarring and deposit of scar tissue in the liver. The whole liver is damaged from chronic injury. This can occur because of chronic alcohol abuse. The liver is one of the first sites that alcohol taken in goes to. It all the all the venous return from the abdominal tract first goes into the liver, and the alcohol can cause damage in the liver. Very clearly, it does cause damage in the liver, and that gets repaired. And then again, they're drinking every day large quantities, so an alcoholic is. So you get repeated injury to the liver tissue and replacement of liver tissue with scar tissue, connective tissue instead of hepatocytes, and you end up with less functional liver that cannot produce enough of the coagulation factors, and those people tend to bleed. People who have hepatitis and inflammatory disease of the liver, and there are a number of causes of hepatitis, including viral hepatitis, also have that problem, and also vitamin K deficiency can lead to this kind of problem. A genetic deficiency in bleeding in hemostasis is, I mentioned earlier, it was hemophilia. It is a genetically based hereditary bleeding disorder caused by the lack of expression of genes. It could be different genes causing it. The gene for factor VIII is quite a common, of all the different hemophilias, it is the most common. Not that hemophilia is that common, but of all the hemophilias, this is the most common, a factor VIII deficiency due to deficiency alteration in the gene coding for factor VIII. 83% of all hemophilia cases are due to factor VIII deficiency. It's called also hemophilia A. It can also occur due to deficiency of factor IX or a milder type caused by a change, I believe, in deficiency of factor 11. So 8, 9, 11. 8 is the most common. It's also called von Willebrand's disease because factor VIII is von Willebrand's factor. The symptoms of a problem with hemostasis are that that when a person cuts themselves or bleeds, they have a prolonged bleeding. It can be painful. It can cause problems, particularly in the joints, because the joints are commonly an area where you do constantly get little injuries, and you can get bleeding. And if you have a deficiency in hemostasis, you tend to get bleeding into joints. Hemophiliacs, for example, often that's a problem. Treatment is with transfusion, injection of the missing factor, and they have some of the recombinant factors have been cloned and are produced commercially, or these individuals sometimes are transfused with fresh frozen plasma. Well, now we get on to the topic of blood transfusion. Blood transfusion is really a kind of a transplant, but it's a transplant typically of cells that are no longer going to divide in the recipient. In terms of transfusions, it's very rare now that whole blood is transfused. Normally they process the blood and they spin it down and remove the plasma, so it's only It's only the red cells plasma is removed, and these are called packed red blood cells. Now, human blood has molecules on its surface that can trigger strong reactions. These are antigens. They're glycoproteins. Glycoproteins are quite good at being antigenic, triggering immune responses. There are actually many different molecules on the surface of red blood cells. They're not foreign antigens in an individual, but if transfused into another, they could be. It depends if the person has those antigens present in them or not. If they don't, then the blood from another person would be non-self and would be perceived as a foreign antigen. There are certain particularly important antigen structures. An antigen is a foreign molecule that you can your immune system can respond to. There are some particularly important antigens on red cells. They include the ABO system and the RH system. Now, it's a little unusual and unfortunate in some ways, but a lot of people first learn about immunity and antibody and immune reactions in terms of blood transfusions. The unfortunate part about that is that there are billions and billions of antigens in our environment around us that could act as that are foreign to us, that our immune system can respond to, but we always have to be first exposed to it. We have to be sensitized to it. You need an initial exposure before you mount an immune response, either a T cell response or a B cell antibody response, except for the antigens of the ABO system. That's the exception. So when you're learning about blood group A and B and A, B, and O, those are exceptions. Those are not the way the immune system works for all the other millions, billions of other foreign antigens. The ABO antigens are quite strong in terms of the kind of responses they trigger, and unlike any other antigen, we already have in us, depending on our own blood group, we have our own ABO grouping, we have antibody against it without ever having been sensitized. And as you probably know, if you're blood group A, then you'll have antibody against B. And if you're B, you'll have antibody against A. And if you're O, you'll have antibody against A and also antibody against B. And if you're AB, you won't have any anti-A or anti-B. It's the unique thing about this is that an individual who, let's say for example, is a blood group A, has antibody against B. They have anti-B in their plasma, although they've never seen B blood. So that's extremely unusual, but that's the way it is. As far as RH is concerned, the key type of RH is a whole class of antigens, molecule structures that potentially could be formed. The most important, the only really important one is the big D antigen. And it acts just like any other antigen. If you get exposed to it, if you don't have it, if it's foreign to you, non-self, you will develop an antibody response to it. But it takes some time. It takes, 10 days, a couple of weeks. Until you get that first exposure, you're not going to have antibody. However, it does trigger a strong antibody response. If you are Rh negative, you don't have the big D antigen, then you will develop an anti-big D, And if you get transfused again later, after having developed that antibody, then it's a problem because that antibody will latch onto the transfused cells and trigger lysis of the cells. So, as I was saying, the important structures on red blood cells are the ABO, red cell antigens, some ABO blood groups, and the RH, or big D. Let's talk about ABO first. The ABO blood groups consist of A and or B, or nothing. Again, if you are blood group B, that means you have the B glycoprotein on your red cell surface, and you spontaneously, naturally have an antibody against A called anti-A. If you're group A, in terms of ABO, we're just talking about ABO, we're not talking about RH. So if you're blood group A, you will spontaneously have anti-B. Okay, this slide shows the blood groups and the antigenic structures on the red cells and the plasma antibodies. This information is not relevant. We're not going to look at that. It's in a US population, and color of skin is not necessarily does not necessarily determine the genetic background of an individual. Okay, so as I said before, if you are blood group AB, you have A on the surface of your red cells and you have B, you will not have any ABO antibodies. If you're B, you have B on the red cell surface and you will have anti-A in your plasma. If you're A, you'll have A on the surface of your cells and you'll have anti-B in your plasma. And if you're O, you will not have A or B on your cell surface, and you will have antibody against A and also antibody against B. RH is different. There are actually 8 different RH antigens which you can have. 3 of them happen to be big C, big D, and big E, and they're fairly common in the population. Mostly we deal with big D. If you have big D on your cells, then you are considered to be RH positive. Like every other antigen that's not part of your own body, if you get exposed to this antigen, big D, and if you're RH negative, then, you know, if you get a transfusion of blood that's D positive, RH positive, then you will at that point develop anti-D, but you don't develop it spontaneously without ever having seen it. So people who are RH negative, they don't have anti-D in their blood plasma unless they get exposed to it by transfusion. They're getting immunized in that manner. And that's true for every single other antigen out there associated with microorganisms or chemical compounds or anything in your environment that's non-self, foreign. The only ones where you spontaneously have antibody is B if you're A, anti-B if you're A, anti-A if you're B, and anti-A and anti-B if you're O. That's it. So if a Rh negative individual gets Rh positive blood, you will get anti-Rh antibodies, anti-big D. And the second exposure will therefore result in a transfusion reaction where the antibody binds onto the cells, the transfused cells, and causes hemolysis. Hemolytic disease of the newborn is a situation that occurs in a Rh negative mother who is negative for big D antigen. If they get exposed to Rh positive blood, in other words big D positive blood, they will form the anti-big D antibody. This occurs if the Rh negative mother becomes pregnant and the father was not every time, because the father could be have big D, little d. So half of that father's children, if the father is big D, little d, then the offspring has a 50% chance of being Rh positive, having the D antigen. Anyhow, the mother who is D negative, Rh negative, could have a pregnancy with a Rh positive baby, and in that way she becomes immunized because and starts to develop an anti-D, because fetal blood typically does get across the placenta, particularly at the time of delivery. In the placenta, the blood vessels of the mother and the baby are very close. They're not directly connected, but they're extremely close. And at birth, when the placenta separates, certainly some of the maternal blood gets across, the baby's blood gets across into the mother. So the mother gets immunized. She gets essentially exposed to the big D on the baby's blood and will develop the antibody because of the big D positive baby's blood cells. Big D positive red blood cells from the baby. Now, that's not of any significance to the mother herself until she gets pregnant again. If she again has a pregnancy and the fetus is big D positive, in other words, Rh positive, then she will have developed antibodies because of the first pregnancy, and the antibodies can cross the placenta and bind to the red cells of the Rh positive baby and cause destruction or hemolysis of the baby's cells. That is called hemolytic disease of the newborn, HDN. In order to prevent this, all pregnant Rh negative women receive an injection with an antibody called a preparation drug called Rogam. And what this is a monoclonal anti-big D. The reason they get it is because this is a antibody that cannot cross the placenta into the mother, and will destroy any baby's cells that get across into the mother so quickly that she doesn't have time or opportunity to become immunized. So this has prevented, for most cases, usually has prevented all cases of hemolytic disease of the newborn, because an Rh negative, big D negative female who's pregnant will receive this antibody, in fact, before the end of their pregnancy, in order to, sometimes there is baby's blood getting across in the mother before delivery. And it doesn't harm the baby because it cannot cross. Some antibodies can cross and others can't, and this is a type of antibody that cannot cross the placenta into the baby. Sometimes transfusion reactions occur for other reasons, minor antigens other than ABO or Rh, big D, and sometimes there is a serious mistake and the blood group is ABO is even incompatible, but that's very rare. Nevertheless, with mismatched blood, in which case in a case where the recipient has antibodies that can bind onto the donor cells, you get agglutination, binding together of the red blood cells, because the antibody molecules have two antigen binding sites. Each antibody molecule can bind to two target antigens, and therefore it can help clump together a lot of the red cells, and that process of an antibody clumping together red blood cells is called agglutination. Okay, it is not called clotting. Many students call it clotting. It is not. It is called agglutination. A term that you should understand. Okay, agglutination. And the result of agglutination due to antibodies in the recipient that bind onto the donor cells in a transfusion is that you can get a diminished oxygen carrying capacity, so a person's PO2 can drop. The clumped or agglutinated cells can impede blood flow in small vessels, and you can get hemolysis. Rupture of the red blood cells is called hemolysis, and that can release free hemoglobin, and free hemoglobin actually is fairly toxic. It can cause damage in the kidneys because it will precipitate in the kidneys, and if there's enough of it, it can actually cause renal failure. So in terms of typing blood, we type it in vitro in a test tube, and we use antibodies that are prepared commercially as reagents, as testing tools to find out what ABO blood group a person's blood is. If the person is AB, their ABO type is AB, then they have A and B. And now this is in vitro reactions using commercial anti-A, which I will highlight as, I will highlight it blue because anti-A antibody, commercially prepared anti-A antibody, is always dyed blue, and I will label the anti-B commercially prepared antibody yellow because it's always dyed yellow. So you look for the reaction in a tube. You take some of the cells from an individual and you put them in a tube. You take, in this case, two separate tubes, and one you put anti-A, and in the other you put anti-B. And then you add the cells, and if the person is AB, their ABO type is, here we're just looking at ABO, not RH. If their ABO type is AB, then you will get agglutination. Positive indicates agglutination, and you will get agglutination in both tubes, in the anti-A and anti-B containing tube. If the person is B, they have B on the surface of their cell, anti-A will not agglutinate, no agglutination, but the anti-B added to the cells will cause agglutination. All right. If the person is blood group A, it means they have A on the surface of their cell, and the anti-A will cause agglutination. Anti-A is a very specific antibody for A. It will bind to A. Anti-B is very specific. It can bind to B. All right. So anti-A binds to A, anti-B binds to B. If you had an antibody against some particular bacteria and you added it to those bacteria, it could bind them together. It could cause agglutination of those bacteria together. Very, very specific. If the blood group being tested with these reagents, anti-A and anti-B, is O, it doesn't have either A or B on the surface, and you will not get any reaction. You will not get agglutination. Now, one thing that can occur with, one problem that can occur in patients sometimes, in people who go into shock, is that they have a lower blood volume, and that, well, the lower blood volume will trigger the shock, and you know, it could be because of a bleed. That's one of the most common reasons for low blood volume. but that can trigger shock and inadequate perfusion of organs and is life-threatening. And so the volume has to be replaced quickly to maintain the overall pressure. Remember, if the volume drops, then the pressure will drop. It's a closed system. If you bleed a lot, not only are you losing the ability to carry oxygen, but you're also losing the pressure in the system, and you don't get adequate perfusion through your vasculature. So the fluid has to be replaced. The best, of course, is with blood if it's due to a bleeding, and if not, then plasma, and if not plasma, then plasma expanders can be administered. There's a number of things that can be given. The simplest thing that can be given is isotonic saline. Plasma volume expanders all have the property that they are osmotically able to draw fluid into the vasculature. So when they're infused into a person's vascular system, they're transfused in, they will be able to increase fluid volume by pulling fluid from the tissues into the vasculature and therefore raising the blood pressure. There are several types that can also be used besides just plasma from the blood bank. There's also human serum albumin that's been purified and is available from a blood bank, or dextran solutions, which is essentially a glucose solution. If all else fails, it's a real serious emergency, they'll put in isotonic saline just simply to increase the total volume of the blood and therefore raise the pressure up. And that's the last slide for Unit 4 on blood. So this is the end of Unit 4, Part 3.